One said, my name is John Crane, and I am a Senior Director at Centering Healthcare Institute in Boston. And today I'm here to just help you understand a little bit more about what the Centering Healthcare model is and how it's impacting health outcomes around the country. So the objectives for today's talk are going to be to introduce you to the Centering Care Framework, to discuss our three large models of centering, which are centering pregnancy, our prenatal care model, centering parenting, which is our pediatric model, and centering healthcare, which is a general model that is used for chronic care conditions such as chronic pain or diabetes care or opioids. Sorry about that. It keeps bouncing back and forth. So.
My computer is acting weird. Sorry.
Yes, it is acting a little strange, but that's okay. We'll deal with it. I want to discuss a little bit about the evidence behind centering and its impact.
Guys, I think these slides have disappeared.
Okay, so we're having some trouble here. Am I muted? Can somebody tell
No,
me?
I think it should be on now. Yeah.
Okay, I just got a notice. Okay, thank you. We're going to talk about how Centering Healthcare Institute supports the dissemination, implementation, and sustainability of the centering care models. I'll describe some of the centering model fidelity and quality assurance processes, and then I'll review a grants program that we introduced at the beginning of this year to provide free technical assistance to new centering practice locations. And this should be of particular interest since Mississippi is in our target area for developing new centering practices. So before I get started, I just wanted to ask the providers in the group, how would it feel to, and this is just a rhetorical question, but how would it feel to not have to rush through a typical 12 to 15-minute office visit, assuming you have the luxury of a 12 to 15-minute office visit? How would it feel to not be stressed because you're running behind schedule? How would it feel not to have to repeat the same fundamental? Yes.
Sorry, we cannot see your slides right now. Sorry.
You cannot see them. Oh, I'm sorry. I did share them.
Okay, now we can.
How's that?
Yeah. Thank you.
Okay. Great. So how would it feel to know that your patients have received and understand the information that they need to make healthy decisions? How would it feel to work with really activated and engaged and receptive patients? And how would it feel to know the care you're providing is having a meaningful impact on your patients and their families? It's okay if you don't know the answers to these questions. Centering can help you get there. So let's take a step back and first look at what is centering. So there are a number of ways to look at centering and describe it, and it depends on your vantage point, where you're coming from. But here are 4 ways that I like to describe centering to folks who may not have a foundational understanding. Centering is an evidence-based and patient-centered framework for providing healthcare in a group format. Centering intervention, it's a clinical intervention, implemented by healthcare providers that uses the healthcare visit as a touch point for engaging patients in their own care and connecting them to other patients and support services. Centering replaces individual appointments with group appointments. However, individual appointments can always be used to supplement group appointments. And centering is defined by a standard set of guiding principles referred to as the essential elements of centering, and adheres to quality and practice standards established by the Centering Healthcare Institute. So once you disseminate that and discern it all down, you come up with something simple that says centering is a framework for group visits implemented by healthcare providers that engages and connects patients and adheres to the essential elements. So the core components of centering are health assessment, interactive learning, and community building. So it's all built around that healthcare visit as a touch point for engaging with patients. The interactive learning component is designed to engage patients in their care and with one another, and then the community building, again, builds social supports and networks of patients. Many patients we find are isolated in their communities, and this gives them an opportunity to engage and develop social connections. So it's really how these are all woven together that really makes the magic of centering. So as I mentioned earlier, centering is really a framework for care, and it's guided by the essential elements, and there's 9 of those essential elements, and we have them here. And these essential elements really form the foundation for any sort of centering practice, regardless of the patient population or the health condition that you are specializing in. So while each of these elements are very simply presented here, when you begin to unpack them, they get a lot more complicated and nuanced in terms of how you do it and what the implications are for your practice. So I'm just going to run through a few of these so that you understand a little bit more about what these essential elements are, because this is really where the model fidelity comes from and the quality assurance that we talk about a lot. So health assessment happens in the group space. This is a really important one because, A, you need a group space to have a group of patients and see them. But more importantly, the reason we provide this is to normalize the process of care for all patients so that they understand that everybody receives care in the same way. And that's always kind of a mystery sometimes when you're on a one-on-one in a tiny exam room with a provider and you don't see other patients getting care. So in a centering practice, typically we set up a small semi-private area of the group space where there's a table or a cot, and we allow the patients are seen there by the provider. So it's semi-private. You set it up so that there's the personal information is not overheard by the other people in the room, but they can see that somebody's back there getting an exam, and that normalizes the care process. And I'm sure you will have a lot of questions about that, but moving forward, I'm just going to go through these essential elements so you understand how they impact the entire model as a whole. Patients engage in self-care activities, and this is a really important aspect as well because what we're trying to do is activate these patients and have them engaged in their own care. And so one of the fundamental processes of centering is when patients come to the group meeting, they begin taking their own blood pressures and vital signs. So they record them, they measure their own BMIs, and they get to know what those numbers mean, because a lot of times we as providers will take those vitals, but we don't necessarily convey them back to the patient, or we don't actually put those things in context for the patient and what they may mean for the patient. Each session has a plan, but emphasis may vary. Now, it's important to understand that centering is usually a cohort of patients traveling across time together in a certain number of visits. So in a centering pregnancy cohort, you may have 8 to 12 pregnant women together of similar gestational age, meeting for 10 times over their second and third trimester. And so each of those group meetings is pre-scheduled, and there should be a plan for those meetings so that they're not these ad hoc, what are we going to talk about today meetings, but the provider's team understands that there's a goal to this visit. There's a plan that's related to where that patient is in their health journey. And so that's to provide context and import to those group meetings. Groups are facilitated to be interactive, and this is a really important one because when you have a group of patients together, facilitation skills are very, very important. We don't want these groups to be didactic teaching sessions. We want them to be interactive, engaging, learning sessions. And that takes a different skill set than providers are generally used to. When you come out of school, you're usually taught to provide the answers to the patient's questions. And in centering, it's kind of the opposite. You're taught to reflect the questions back to the group, let the group respond to the question and discuss the question. And by doing so, you enter into more engaging conversations, more informative conversations. And the facilitator is there, the provider who is also a facilitator is there to help guide the conversation so it doesn't get too off track. But the theory here is that there is wisdom in the group, and the patients have a lot to share with one another as well as the provider. And that's one of the magics of centering, is that the providers come away from these groups learning as much as the patients do. Time for socializing is built into a centering visit so that patients get to know each other, and you'll find that there's a lot of groups that form Facebook groups and stay connected even after their experience in the group has completed. And so you find a lot of social supports and networks are being built through centering, which again addresses a lot of that social isolation that a lot of patients can sometimes feel. Groups are always conducted in a circle, and this is really important because everybody in the circle is equal. Again, it helps to address the power dynamics that sometimes impact the relationship between the provider and the patient. And so, again, in a centering group, the provider and the staff facilitator are both members of the group, permanent members of the group, and all members of the group are of equal value and equal status. Group members, including facilitators and support people, are consistent. And this is another thing. You may be aware of group models where they're drop-in group models and the group membership changes. And that's fine. There's nothing inherently wrong with that, except that one of the things that we find is that a lot of those social connections are built up after 2 or 3 group meetings, and that it really helps to have a consistent cohort of people meeting for some period of time. And so that's, again, to support that social engagement and social network building that's so important to driving the health outcomes the health outcome improvements that we're seeing in the centering care model. And group size is optimal for interaction. So this is one where it depends on what you're doing with your groups, what the health condition is. So for pregnancy, we're recommending 8 to 12 women in the group, but they can be accompanied by their partners or some family member or support person. In a centering parenting pediatric group, it's slightly smaller because it's a little bit tougher to corral all those babies that are there. So and you're usually talking about a parental dyad of some kind, or so you want to size the group so that it works for the group members. And this is something you learn through doing groups with your patient populations and through trial and error and determining whether, what works best for you. And we provide guidance around this, but there's no hard, fast rules around what's an appropriate group size. Another really important aspect of centering is that there's always ongoing evaluation. And evaluation is at 2 levels. One is, of course, the health outcomes evaluations. You want to know that the work that you're doing is having a positive impact on your patients. And the other is process evaluation. So you want to know that you're adhering to the model and the practices that deliver those health outcomes or have proven to deliver those health outcomes in other settings. And so we really are always invested highly in quality, and you need to do continued evaluation in order to maintain and sustain that quality at a centering practice. So when you think about returning to our framework, you can see that once you understand and implement the processes effectively, it can be used to address a broad range of patients and health conditions simply by adapting curriculum, number of visits, provider types, etc. So we have groups around the country doing diabetes, HIV groups, cardiac groups, chronic pain, pediatrics, opioids. If you name the condition, there's probably somebody doing or thinking about doing a centering group around that visit type or health condition. So let's talk a little bit about how a centering group visit is structured. So a typical visit is 90 minutes to 2 hours long, and it typically begins with the arrival of the patients. What they do is the first thing they do in the door is they take their vital signs. And there's a table station set up for them to do each of their important vital signs, and we provide them materials on which to record their data. And you could have your centering team members helping patients with this, just ensuring that they are recording the data correctly and using the blood pressure cuffs and other such things correctly. And once they've been to a couple of visits, they all get pretty good at doing this. So that is proven to be quite effective. After they've taken their vitals, one by one, the billing provider sees the patient for a very quick and brief assessment. So again, in the centering pregnancy model, that would be a belly check and 3 to 5 minutes sit down with that patient and some asking the fundamental questions you need in order to qualify that as a billable medical visit. And while one patient is being seen by the provider, the other patients are socializing, and we'll talk a little bit more about that in a bit. After all the patients have been seen, all the group circles up. The provider, their co-facilitator, all the patients, they circle up and they work through the curriculum that has been assigned for the day. And when I say assigned, it's not assigned to the patients per se, it's assigned to the facilitators to talk about that day. And it's important to also realize that this is a flexible situation whereby you may have planned to talk about something in the curriculum for that practice, for that visit, but something may come up in one of the assessments that seems to be an important topic that folks want to talk about. And so another tenet of centering is that you talk about what's important to the group to talk about. So again, this is one of those areas where you feel like you have to get through the material to feel like you've addressed all the issues, but sometimes the most important issue is the one that the patients want to talk about today and now. And those are sometimes some of the richest conversations that we have. There's usually a short break to allow, for a bio break or for getting some food. We ask that practices provide healthy snacks to patients, water, granola bars, whatever that is, just to give them something around which to sort of circulate and socialize for a short period of time and connect around something personal. The group circles back up again, continues through the curriculum as necessary, and then at the end there's always a formal closing to the group so that this brings finality and conclusion to the meeting. And this is a 2-hour group, so one of the things that we see here is that the groups start and end on time, so that when you have a centering practice, patients are showing up at the appointed time, and the group helps to drive them there at the appointed time, and they start and end within your time. So again, if you have a centering cohort, centering pregnancy cohort, where you know you're going to be meeting for 10 visits over the last 2 trimesters, you know when those visits are going to occur. Your patients know when those visits are going to occur. They may be occurring every Tuesday at 7 o'clock in the evening or whatever, but they will always know ahead of time once they're enrolled into that group when that group is going to meet. Of course, all of this, at the center of all of this activity is your facilitation team, which includes the provider facilitator, who is the billing provider, and a staff facilitator who can be an MA or a nurse or a community health worker or a social worker or an administrator, somebody who is trained in centering facilitation and doesn't require 2 billing providers to facilitate the centering group, just one so that you can actually bill it as a healthcare visit. This team approach enables the care team to manage the group effectively, especially during the time when the provider is conducting those individual assessments. So I've mentioned centering pregnancy a few times here, and that's our original model and our flagship model, and it's a model around which most of the evidence has been built. And so, again, I've mentioned this earlier, but this model really brings cohorts of 8 to 12 women together. Those women are of a similar gestational age. They meet for a series of 10 visits beginning in the 2nd trimester. The visits are all match the periodicity schedule for ACOG and ACNM. And so they're consistent. They're consistent and with all of the medical practice guidelines that are out there. The other model that we have is a centering parenting model. This actually is early childhood, first 2 years of life, although some of our centering parenting groups are in their 5th and 6th years, believe it or not. Centering parenting is the early childhood pediatric model centered around AAP's Bright Future practice guidelines through the first 24 months. Centering parenting brings 6 to 8 moms, pet partners, support people, and their same-age infants together in community with their healthcare providers and other parents who are experiencing similar things at the same time. And so you can see the rooms can get kind of full. And then centering healthcare is the newest iteration of centering, and this is the one where we're applying all of the centering framework principles to the chronic care conditions. So we do have a lot of practices that are doing this, as I mentioned, in the framework for HIV and opioids and chronic pain and diabetes. And so you'll be hearing more about this down the road, but this is a fairly new implementation for us and an expansion of how we're applying the centering model in the field. So let's talk a little bit about some of the benefits of centering, and of course you can start with the provider benefits, because centering groups start and end on time. There's more meaningful time with patients. There's reduced repetition of messages. There are deeper, more meaningful conversations. There are stronger bonds with patients. Patients do most of the work in centering, because in a good centering group, patients do most of the talking and the providers just do the facilitation and the listening and course corrections. It changes the pace of practice for the providers. It reduces stress. And many providers feel that this is the best part of their day when they're doing centering groups, because it gives them a chance to decompress and they find them engaging, fun, and energizing. So it addresses one of those quadruple aim concerns of provider burnout. Patient benefits are great for centering. There's no waiting, there's no lines. If your group is going to start at 7 p.m., as we said, or 2 p.m., it starts on time. All the appointments are pre-scheduled. Patients get to spend a lot more time with their healthcare team under this model. So instead of having 10 or 8 individual patients over a 2-hour period, you're getting, they're sharing your time, but that's more meaningful and more productive time. It's instead of a production line approach to patients, it's much more holistic and engaging and informative for everybody involved. There's a chance to meet and share with others with the same questions and needs. Centering time is 100% productive, both for the patients and the providers. Sessions are informative and fun, and of course, as I mentioned, we like to offer snacks in our group. What are some of the benefits to practices? Well, you get very high patient satisfaction ratings. You see improved quality outcomes, and that's important in the evolving world of alternative payment models and payment for quality that we're seeing in the payer community. So it's a really important benefit to bear in mind. There's improved staff satisfaction around centering. It's an innovative care alternative. And in some states, depending on what state you're in, there is a possibility of receiving enhanced payments from payers for centering patient visits. Now, that's not true in Mississippi, but I can tell you that Centering Healthcare Institute is certainly talking with Medicaid and the payers around this or other potential options that we might be able to offer. So we actively engage in discussions with payers around the country to try to share those health savings, the cost savings that they're enjoying to improve health outcomes back to the providers who are delivering the care. And that will probably, we'll get into payer benefits here, and then we'll talk a little bit about the evidence. But the benefits to payers are that there are better health outcomes, there are lower costs of care, their HEDIS measures are improved. It meets value-based purchasing goals and guidelines for the payers. It's supported by a body of evidence, so it's an evidence-based practice that they can get behind. It's validated by an independent third party, which is CHI, Centering Healthcare Institute. Payers know what they're buying because there's a body of literature and evidence behind the model out there. And it meets the quadruple aim of better health outcomes, better patient experience of care, lower cost of care, and better provider experience of care. And so, again, let's talk a little bit about some of the evidence and the outcomes that we're seeing. So I first want to point you to our website, which is centeringhealthcare.org. And when you get there, you can choose why centering. You can then go to evaluation and research, and then down here you see a bibliography, and it's a 16-page bibliography of scholarly research articles, randomized controlled trials, opinion pieces, and a whole bunch of other information, private studies done by private foundations and institutions regarding centering. And I would encourage you to download that and look at the body of evidence because it's quite extensive in support of the model. So what we usually talk about are the two large studies that are being done, that were done. The first was in 2007 with the randomized control trial. It started at Yale. It was done at 2 locations. One of them was in Atlanta, 1,047 women, and they found a 33% reduction in the risk of preterm births in centering patients compared to those who received only individualized prenatal care. Among African Americans, they found that the rate of reduction was 41%. So that was a pretty astounding finding back in 2007. In 2012 in South Carolina, there was a study done that showed, you can see 316 women in centering compared to 3,700 or so out that were in individual care. They found a 47% reduction in risk of preterm birth in centering patients compared to those receiving only individualized care. More importantly, or more astoundingly, in that South Carolina study, they actually eliminated the birth disparities, the racial birth disparities. And this slide just shows that the African American birth rate, preterm birth rate, went from 12.4% down to 7.4%, while the rate among white women went from 9.8% to 5%. That was a pretty profound finding of this study. I would also mention that this study was done in South Carolina, and as a result of that study, South Carolina launched their birth outcomes initiative, and one of the primary legs of their birth outcomes initiative was an expansion, a statewide expansion of the centering pregnancy model. And they put together a structured program which includes a research study, funding to help offset the cost of starting up centering at practices, as well as enhanced payments to practices to help them sustain centering pregnancy and pass back those savings back onto the providers, as I was talking about before. So that's a really, really key element of centering these days. South Carolina is at the leading edge of doing some innovative things around innovative care models. So in 2016, their research team published a report on what they were seeing in terms of cost savings. And so one of the things that they've discovered is that they saw a 36% reduction in preterm birth, and that the average preterm birth saved them over $22,000. They reduced their low birth weight rate by 44%, for an average savings of $29,000. That's per avoided incidence of low birth weight. And their NICU admission rate dropped 28% among centering patients, with an average direct cost of $27,000 per NICU admission. So overall savings in South Carolina has been about $4 million directly attributable to centering care. And so that comes out to about $3,100 per patient that is seen in centering. So that's $3,100 for every patient that is seen in a centering group over that time period. That's a pretty astounding number. So what are some of the success factors that it takes to get centering going? First is provider and staff buy-in, because centering doesn't happen unless the providers are willing to do the centering. That's That's the first and foremost. The second most important thing is leadership support and organizational commitment to making this work, because it does take change, and the change does impact the organization at large. Obviously, you need to have space to bring your groups together. It helps to have enough patient scale in order to fill those groups so that you can schedule them frequently and have enough patients to make them pay off from both a productivity standpoint as well as from just a group dynamic standpoint. It takes a willingness to remain true to the model, to the evidence-based model, and ongoing Q&A and training, because staff turnover and administrators turnover, and there's a constant element of education and training involved in implementing any new model, regardless whether it's centering or something else. It requires measurement and ongoing documentation of outcomes and process, continual education of staff and leadership, and then, of course, the part that we're looking to also do is the payer support piece, because, again, in the climate that the healthcare system that we work within, the payers pay for the care, but they also reap the savings from any sort of innovations that the providers implement. So what are the risks and challenges to centering? Well, the first risk is drifting away from the model or lack of ongoing training, and we see a lot of practices that succumb to losing key staff. They put a lot of faith in key leaders in the staff, and those leaders leave, and then the centering program loses its rudder, and then things fall apart. So turnover of staff and administrators, and again, there's a lot of turnover, and every time there's turnover, there needs to be re-education and reaffirmation of the reasons why you're doing it. Loss of resources, again, it gets back to leadership buy-in and commitment. So if for some reason your organization reschedules your centering space, takes it away from you to give it to another department without checking with you first, that could have serious ramifications for your centering practice. Inappropriate productivity measures and expectations, and this really goes to when you start looking at group care models, you have to change your standard productivity measures and adopt new measures that actually take into account this change in practice. And then there's, of course, lack of resources and time to scale. It does take time to implement a new practice model, and that takes some time to let it take root and grow within your organization. So just a little bit about who Centering Healthcare Institute is and what we do. So first of all, we're a 501c3 not-for-profit organization, but we're really the standards organization for the centering care models. What we do here out of the Boston office is we provide implementation support services, practice management, and quality assurance tools to the practices that engage with us. We do all of this facilitation skills training around the centering model. We provide site accreditation, and we have a facilitator certification pathway so that when you do get trained as a centering facilitator, there's a pathway to certification to acknowledge that. We provide curriculum, promotional, and support materials, and we do a lot of advocacy, payment reform, and community outreach part of our work. So right now, who's centering around the country? There are 500, more or less 500, probably a little bit more, sites that are implementing a centering model. And in the next 5 years, we're expecting to grow that to about 1,600 sites around the country. And if you are ever interested in knowing where they're centering, you can go to our map on our website, click on the locations link. And here I've highlighted Mississippi, and sadly we don't have any centering practices in Mississippi yet, but we're taking steps to change that in the near term here. So I'll tell you a little bit about our grants program in a second. So as part of an outreach effort and some funding that we received, we're able to offer technical support implementation services to practices that are interested in starting up centering or expanding their current centering practice. In Mississippi, that would obviously be starting up centering practice. It could be a centering parenting model, which we're hoping it would be. It could be a centering pregnancy and parenting model. It could be centering parenting and centering healthcare for chronic conditions. So the important thing to know is that we're in a position to offer a free implementation support package and training package, which is typically valued up to about $30,000, depending on how you structure it. But we can provide that to, we have a grants application process that you can go through to qualify for that. And that includes the implementation support for 2 years, free basic facilitation training for your care teams, a one-day site visit from a CHI consultant to meet with the leadership and staff, and free site accreditation. So what we're asking for in return is a leadership commitment to success, including staffing and budget support, ongoing budgeting support, commitment to implement centering pregnancy and centering parenting models, or centering parenting and centering healthcare models, commitment to achieving accreditation within 24 months. And we do ask that you pay a small annual license fee for each centering location that you plan to start up, which is $250. And that's more of a contact payment that we maintain in order to know that your account is current and active. So who should apply for these grants? We're looking at community health centers, rural health centers, academic medical centers, practices and expand to multiple centering care models, teaching practices with student or resident integration, integrated health systems. So really, pretty much the gamut. If you think you might be interested in applying, we would encourage you to apply. If we can't provide you with a grant, we can probably find another way to find some funding to get you started, either through us or through another organization. And so how do you apply for that? Well, if you go to our website, you see what we do, and then under implementation grants, this is the bottom of the implementation grants page that I'm showing you, and you can see that there's a section called How to Apply, and you can see that there's an RFP there, and there's also links to the online application form. There's also some questions and additional help. We have a community forum that you could link to and post a question if you needed to. And at the very bottom, you'll see that there's webinars that we're hosting around these opportunities. So there's one in a couple of days. And these are open for audiences across the country. So today's webinar is strictly limited to CHAMPS members and the CHAMPS program, but on Friday there will be a webinar specifically around this grants opportunity for practices around the country. And then again, we'll repeat that on March 1st. So there are ongoing opportunities to learn about this. The grants deadline, the next grants deadline is March 15th. However, we will be, if that seems a little short in time, we will be offering another round later in the year, probably in the mid-fall, to be precise. So the exact timing on that is not yet established, but we're looking at October-ish, November-ish to have the next round of grant applications if we can't hit this round. So just wanted to thank some of the funding partners that we have, just so you're aware: Valhalla Charitable Foundation, W.K. Kellogg Foundation, Anthem Foundation, March of Dimes, ACOG, American College of Midwives, AMCHIP have all been strong supporters of centering over the past 17 years or so. So right now, I'd just love to open it up to questions and hear what I didn't cover or what I should be covering more in this presentation. So please feel free to ask me anything you